I'm going to keep my portion very brief so that we can hear primarily from our panelists today. So I'm just going to do some quick introductions of our panelists and then we'll get into it. So today we have Dr. Philip Coffin, Dr. Carla Wagner, and Phil Feudy. Dr. Coffin is a board certified and practicing internist, infectious disease specialist, and addiction medicine specialist who directs the Center on Substance Use and Health at the San Francisco Department of Public Health. And works on clinical trials, assessing medications and other interventions, as well as epidemiologic studies addressing multiple substance use disorders, opioid safety, overdose prevention, HIV prevention, and hepatitis C treatment. Dr. Carla Wagner is an associate professor of social and behavioral health in the School of Community Health Sciences at the University of Nevada, Reno. She conducts public health research to examine the individual, social, and environmental factors associated with drug overdose and HIV among people who use drugs and other groups at risk. We've been very lucky at UNM that we've been able to collaborate with Carla on a couple of projects, and so very happy that she was able to join us today. Philip Feudy works up at the Mountain Center up in Espanola, again, a longtime collaborator with us, so really grateful that he's here to provide some context around methamphetamine in New Mexico. He's provided underground syringe and naloxone distribution in rural New Mexico back in the early 1990s, was a harm reduction volunteer for the AIDS Resource Center of Wisconsin, a harm reduction outreach specialist for Albuquerque Healthcare for the Homeless, and the harm reduction program manager for the New Mexico Department of Health from 2002 to 2006. He's been involved with education and harm reduction efforts around methamphetamine, safe access to medical marijuana, and the use of ibogaine for the treatment of substance use disorder. He's currently the harm reduction program manager for the Mountain Center in northern Santa Fe and Rio Arriba counties in northern New Mexico, and is a consultant administrator and trainer for the federal STR, PDO, and SOR overdose and OUD grants in New Mexico, and has a new PFS 2020 grant to examine and develop resources targeting polysubstance use in New Mexico. So we have a great panel here today. Thank you all very much for joining us today. And I'll turn it over to Christina now to get us started with the panel.
Thanks, Catherine. So our first presenter today will be Dr. Philip Coffin.
Hey everyone, I want to give an extra thank you to everyone whose video is on. It is much easier to talk when you can see some responses and get a little bit of a sense, as much as you can on Zoom, as to if you're headed in the right direction or if there's interest in other domains. So I'm going to share some slides. I don't have too many, but just to give a little bit of context. So I'm thinking about a couple of major issues with methamphetamine and why we're concerned about it, and also sort of how the concerns might affect the research pathways that we pursue. So I think we all know that stimulants and deaths have been, ED visits and deaths and hospitalizations have all been on the rise for stimulants, particularly methamphetamine, particularly in the western half of the country, although it's spread to the east to some degree as well. And but thinking about these visits, the construct is really radically different from how you would think about it with opioids. Opioid overdose is respiratory depression caused by more opioids in the system than the system can handle at a given moment in time. That's a pretty solid definition of overdose. There's controversy. People who, take prescription opioids don't feel like they can overdose. Oftentimes it's multiple drugs on board that are contributing to overdose with other depressants, but still it's more opioids in the body than a body can handle at a given moment in time, resulting in respiratory depression or arrest. With stimulants, well, I'll zero in on methamphetamine. It is so different and so varied. And the whole terminology of overdose, which is problematic for opioids, is probably fatally problematic for stimulants. And I still use that term because it's so convenient, but it really is terrible. And I think we need to move away from it. So these stimulant-related ED visits, the vast majority of them are either, for methamphetamine, it's either agitated delirium, or what people in the field might refer to as overamping, and or a psychotic episode, all of those things. It's these psychiatric complaints, or it's cardiovascular, so chest pain and related cardiac complaints. Cocaine gets a lot more of the cardiac than methamphetamine, but you still do see it with methamphetamine. I used to draw a picture at harm reduction conference talks of draw the human body. In the brain, you'd put meth. In the heart, you'd put cocaine. In the lungs, you'd put heroin as their primary sites of toxicity. The deaths have also been going up. And what's really interesting about deaths, when you look at methamphetamine deaths, those were rising separate. Methamphetamine without opioids, deaths were going up really steeply through about 2016, maybe 2017, because that's mostly on the western half of the country where we weren't seeing fentanyl much at that point. Since then, the increase that we're seeing with methamphetamine seems to be all driven by fentanyl. So we definitely saw an increase in meth-related deaths from 2009 to 16 or 17. But then after that, the further, more recent increase seems to be fentanyl. And the big question here is, are meth fentanyl deaths really just fentanyl deaths? When we look at older studies, so this was data through, I think, 2016, maybe 2015. We looked at stimulants. We looked at stimulants together, as in meth and cocaine, and separate, meth versus cocaine, and we compared stimulants together versus opioids. When we looked at these deaths, the stimulant opioid deaths looked like opioid deaths. The demographics were the same. The additional causes of death were the same. The comorbidities noted by the medical examiner were the same. So you didn't see very much cardiac in these stimulant opioid deaths. They were really opioid deaths. And when you read the case narratives, they sounded a lot more like opioid deaths. They were more, oh, they used and fell asleep and they were snoring and woke up in the morning and they were dead. And it gets coded as a meth and heroin death, because there's a bunch of meth in the system. But that, that really sounds like a heroin death, not a methamphetamine death. So I don't know if this holds for fentanyl, for the stimulant fentanyl deaths. And it's a really big and interesting question. Are these meth fentanyl and coke fentanyl deaths, are they really fentanyl deaths? I think they are, but I don't know that for sure. The other thing is, for most of the deaths that are real stimulant deaths, let's say stimulant without opioid deaths, what you tend to see, how are people dying? It's not respiratory arrest, right? It's not, we oftentimes say heart attack or something like that. That's kind of a lay term for cardiovascular cause of death. There's a ton of cardiovascular causes of death. They tend to be electrical conduction, which is really hard to detect on autopsy. You can't tell somebody had a fatal ventricular arrhythmia unless they had like a massive heart attack that led to the fatal ventricular arrhythmia. Just having, torsades because meth prolonged your QTC and then you died, you can't detect that on autopsy. So it's really hard to pin down and say what's causing these stimulant, quote, overdose deaths. But the studies to date really, I think the best studies can account for maybe 40% of stimulant overdose deaths as being due to cardiovascular causes. And then there's a chunk, especially for methamphetamine, that are cerebral hemorrhage. So bleeding into the brain. And that's basically due to chronic cerebral hypertension from long-term use. So these deaths should be older. We shouldn't see these, you shouldn't see a methamphetamine quote overdose death in a 20-year-old person, because it takes a while to develop the kind of cardiac disease that's going to kill you, with the rare exception of somebody who might be genetically vulnerable to a cardiac arrhythmia. So there's some rare exceptions, but it should be pretty uncommon to see these young deaths. So when you're seeing, let's say, meth, fentanyl deaths skyrocketing among 20-something-year-olds, you're dealing with a fentanyl problem. Probably. And you're probably, the meth is there probably as a bystander. Although there's two ways it could contribute. One is it can be a marker for behavioral patterns. So people who are using stimulants with opioids may be engaging in riskier opioid use. So sort of a marker of risk. And then the other thing is, I haven't seen studies really digging into stimulants plus fentanyl. So I don't know. It is still possible that fentanyl, which is different in so many ways from other opioids, it's possible that there is some interaction with stimulants that enhances the risk of fentanyl in the presence of stimulants. I haven't seen those studies. I'm doubtful of that, but I can't say that that's not a contributing factor. So thinking about this, and thinking about the real risk of stimulants being this cardiovascular disease and the development of cardiovascular disease, it brings you to the idea of what are the treatments for methamphetamine use. And we have a bunch of things that have been tried, right? Probably the most promising are some of the amphetamine type stimulants, naltrexone, bupropion, mirtazapine, topiramate. These are really kind of the most promising ones. Nothing's a slam dunk. Nothing is fantastic. Got some future things, some things in the pipeline, probably some combinations that will result. We have enough that as an addiction medicine doc, I can sometimes try one thing, add on another, and just do experiments, N of 1 experiments, and see what combination works best for a patient, which is really cool clinically that we've gotten to the point where we can play around and see what helps somebody the most. But scientifically and FDA approval wise, we're not there yet. There are some major limitations to all of this research, and those limitations are tied to the toxicity issue. So if the reason people are dying is because of cardiovascular disease and cerebrovascular disease, which we think is the main reason people are dying from stimulants, not necessarily the stimulant fentanyl, but from stimulants, that's probably the main reason. Then this is going to be the result of cumulative chronic use. So how much meth have you used? Not did you use meth last week? It's not that I used meth today that killed me. It's the fact that I used meth every single day for the last 8 years, and it was a lot of meth. That's what killed me. So if we have medications that can reduce somebody's meth use, so many of these studies, several of my own negative studies, participants would report that, yeah, I cut my meth use in half. I'm like, we didn't detect any reduction in use. They're like, yeah, I still use every day. I just use half as much. And so we can't detect that because we don't have any quantitative assay for how much meth somebody's using. It's only qualitative. So we might be getting somebody to reduce their use to 10% of what they were using before, and we detect zero reduction because they're still using with a similar frequency. Whereas that reduction in use is probably clinically very, very, very meaningful for their well-being and their longevity. And then there's the outcome of choice. What is our outcome? If we had this quantitative measure, I would say that should be our outcome. Short of that, we're stuck in this battle with the FDA and others as to, is the outcome abstinence? Is the outcome reduced frequency of use? Does it have to be end of treatment abstinence? So there's all these different models. They're tough with stimulants. It's harder. It's a different drug. It's a different class of drugs than the other drugs we've developed therapies for. And then medication adherence is, of course, a huge issue. I'll just mention briefly our own in San Francisco 2 mirtazapine trials. Adherence in these trials is in the 40% range. We saw significant reductions in use. The first trial, you can see pretty clearly the black line is the mirtazapine. The second trial, the red dots are the mirtazapine. We treated people through 24 weeks, so right about here. And then the 12 weeks at the end were off treatment, and we still saw a reduction in use that sustained for 12 weeks off of treatment. There was also, of course, CTN-068, which you've all heard about, where with naltrexone plus bupropion, this is, of course, in the context of the bupropion was incentivized with $5 a day for taking the pill. So you had adherence upwards of 70%, and it was high dose bupropion. So, you know, personally, I think it's possible that this is really a study of high dose bupropion with really good adherence. So, you know, clinically, I can't access extended release naltrexone for these patients. So, but it gives me a little more faith in the bupropion story, which has had mixed data through the years. I will stop there in the interest of time and letting others speak.
Thank you so much, Dr. Koff, and thank you very much for that wonderful presentation. Our next presenter is Dr. Carla Wagner.
Did I do it? Are you seeing my screen?
Perfect, yes, we can see.
So now for something completely different, but kind of related and nicely following up, I think, on Phil's talk. I'm trained as an anthropologist first. I'm a social behavioral scientist. So I'm going to talk a little bit about a study that we're conducting with our colleagues at UNM and several collaborators funded by the Mountain West CTRIN, which is the Clinical Translational Research Infrastructure Network that involves some of these people, but not all of these people. And we had a little multi-site pilot grant to look at methamphetamine use specifically in the context of the opioid epidemic. And it was largely driven by some of these things that Phil is hinting at, right? All of a sudden, methamphetamine was killing lots of people, but methamphetamine shouldn't be killing people the way opioids kill people. And what the heck is happening out there, and what the heck is happening in places where we have both high rates of opioid use and high rates of methamphetamine use that are not San Francisco, because we actually have a kind of a different drug supply here than in San Francisco. So those questions inspired this little study. We have multiple sites. It's a multi-site trial. So we have a site in New Mexico and a site in Nevada. We've been collecting data in Northern Nevada in Reno and Southern Nevada in Las Vegas and in the Rio Arriba area and Albuquerque. Several of our esteemed collaborators are on the call. And basically what we set out to do is look at patterns and prevalence of methamphetamine use in these two states that have historically had a lot of opioids and a lot of methamphetamine for a long time, and try to dig in qualitatively a little bit to this idea of methamphetamine overdose and talk to people who were using drugs about what they understand to be an overdose, what they're feeling, what the drugs are looking like, and kind of what their experiences have been. And then think about harm reduction, prevention, and treatment approaches that might be feasible and acceptable to the people who are using. We accomplished this through a little cross-sectional mixed method study that got put on hold really early because of COVID. So we had grand plans to do a 280 person survey. We got about 25 people into that survey, and we did qualitative pilot interviews, and now we're just waiting for our no-cost extension to get approved. So we have a handful of qualitative interviews, a handful of quantitative interviews, but a lot of really rich data from the qualitative interviews, and that's what I brought to share with you today. When we set out to do the qualitative interviews, we were really just asking people, tell us what's going on. Why do you use? How do you use? How do you integrate methamphetamine use and opioid use? How has your drug use changed over time? We know there have been a lot of changes to the supply side of things. How has price and quality and availability changed over time? And how has that impacted your use? Have you ever experienced what you would call a methamphetamine overdose? And what does that look like? And how does it work? And how does it feel? And then we asked people, and I think specifically and nicely to follow up on what Phil was talking about, we asked people what their past experiences have been with treatment for methamphetamine use disorder and what their interests might be in the future if any of these meds that are in the pipeline actually get into people's hands in a meaningful way. What would they want it to do? How would they want it to feel? What are their preferences in terms of dosing or mode of administration? So just a quick snapshot of the people that we talked to so far. We did 21 qualitative interviews, 35-ish years old, about half women, about half Latinx, about half people living without homes, a third employed, and about a third having been incarcerated in the last 6 months. So, as you might expect, when you ask people who are using methamphetamine, have you ever had a meth overdose? They say things like, no way, that's impossible. You can't OD on meth. And then this guy, and these are two quotes from the same guy who I end up talking to a lot out there, and he has a lot to say about this, but he's been using for a really long time. And so he has kind of a long history of what the meth looks like and feels like. But he's basically saying exactly what Dr. Coffin is saying, right? Maybe you have a weak heart and your heart gives out and you die, but that shouldn't be happening. You're gonna nod out, you're gonna overamp. You just hit this wall and you can't take it and you pass out. In all the people we talked to, only 2 people talked about somebody dying subsequent to methamphetamine use. And we think that those 2 people were talking about the same person who died. In another study, I've been out talking to people who were also talking about using methamphetamine and waking up being told that they had an overdose, snorting a big fat line and nodding out, I can't open my eyes. And we also have people out in the field using fentanyl test strips. And this is some of the stuff that Phil Feudy's going to talk about when I'm done, kind of what that might mean, because people are testing their meth with fentanyl test strips and seeing positive results on those fentanyl test strips. However, we don't think they're diluting, we don't think they're doing the test strips according to the appropriate dilution protocol. So I don't know how much to trust those test strip results, but our syringe access folks are reporting that 70% of the meth they test is testing positive for fentanyl using the protocols that they're using, which might not be accurate. So those might be a lot of false positives. And then, so again, here's some more experiences related to the kinds of things that Phil was talking about. People talk about a continuum from really bad, scary kind of psychological things going on to sort of spiritual and enlightening and mind-opening experiences on methamphetamine. Fear, seeing demons, but also opening you up to a new level. So people are having scary experiences, but also having really positive experiences. Some people have a theory that injecting makes those negative, scary experiences worse. People talk about injecting and having a really, really bad trip and then switching to smoking as a harm reduction response to that, because it's a little bit of a mellower high. They don't get the same kind of ampy and scary experience that they do when they were injecting. We asked people specifically, when you've had a negative experience using methamphetamine, have you sought medical care? Like, when does this rise to the level of you need help? And it was very rare for people to say that they took themselves or took somebody else into professional medical care for help. When they do, it is, as Phil talks about, people just flipping out. And when we got there, they didn't know what to do. And this is a quote from another study, but it was meaningful in terms of thinking about this context of caring for people who are having these scary experiences. We have another study in the field where we're talking to ER docs about post-overdose care in the emergency room. And we keep talking about opioids and they keep saying, yeah, but meth, I've got opioids under control. Tell me what to do about methamphetamine. Tell me what to do for the people who are coming in with methamphetamine related concerns, because I don't have the tools for that. And that came up a lot for us talking to providers, and then echoed by people using drugs saying we get there and they don't know what to do for us anyway. We asked people, what do you do to reduce the harms you experience? And they said the things that we would expect them to say, which is switch to smoking, take a break and get some sleep. I try to drink lots of water. I try to make sure I'm fed. This woman talks about, so here's somebody, she was using with somebody who said, how do I know if I'm having a heart attack? What do I do when my heart starts feeling like this? She said, get a Benadryl or a glass of milk. It'll calm your heart down. So people are understanding the cardiovascular stuff and they're thinking about ways to calm down, but otherwise they don't have a lot of tools. When we asked them specifically about their interest in a future medication that could treat methamphetamine use disorder, several people said it needs to function the way my methamphetamine functions. It needs to give me the energy. It needs to put the life back in me. Many people are using methamphetamine to adjust the experience of their opioids, so adjust their methadone or their heroin high. So they want that stimulant feeling. And if they're going to get treatment, they want that treatment to not take that away. And they were kind of all over the board in terms of modality and dosing. Some people said, I don't want to take a pill. People will forget about it. They'll lose them. Do a shot or an implant, something that will last longer so you don't have to worry about daily dosing. But then other people said daily dose would be fine. Some people said whatever I can get. But, so they were kind of all over the board about when and how. So we have much more data from the study. And one of the things that we have that we haven't looked at yet that I'm interested in looking at is we have self-reported drug use versus urinalysis. So we asked people what drugs they had used, and then we had them give urine, and we're looking at correspondence there, less from the perspective of validating self-report and more from the perspective of seeing if there's anything coming up that people aren't expecting to come up in their urine. So we're hopeful when we get more quantitative surveys that we'll be able to do a little bit more of a robust job looking at that. And then we'll get back out there into the field and ask more of these questions in a quantitative way. So I will leave it there. And Phil Feudy has, I think, many things to say to follow up on some of these data points.
Thank you so much, Dr. Wagner, for your wonderful presentation. Phil Feudy.
Great. Hello, everybody. And yeah, thanks for that. I do have a lot to say on this, and there definitely won't be enough time. I don't often in professional contexts lean into or usually even identify myself as a person with lived experience, but on this particular issue, my life has been speed involved for 40 years now, pretty much every different angle imaginable on this. And so in my lifetime, this is the third wave of methamphetamine, interest in methamphetamine happening across the country. And this is the first time that that the word overdose has ever been applied to it. Back in I won't even talk too much about the before times. I can tell you the first time that I went to access treatment, and it was at the peak of the crack cocaine epidemic in the United States. And I told the intake people what I was there for. And they were like, oh, wow, we thought you guys were extinct, right? Like we were so far off the map. And in the peak of the last one, which was around 2005 and 2006, for people that were paying attention, there was, that was at the height of the do-it-yourself methamphetamine craze across the country. And there was all kinds of information in the news about, meth lab this and meth lab that. And it looked very similar to what we've seen recently with fentanyl hysteria. Law enforcement wouldn't go into houses unless they had full hazmat suits on, and chemical cleaning companies and communities were passing legislation that houses needed to be condemned, confiscated from the property owner, and then condemned and gutted and rebuilt in order for, because of the contamination and things. And my favorite was this methamphetamine was linked to hypersexuality, high-risk sexual behavior in 2005 with a person with something they were calling super AIDS with an individual in New York City. And so a lot of the focus and attention was on that kind of thing, but nobody was talking about overdose, right? And so about 2 years ago, the Department of Health here issued one of their alerts, press releases, and the headline was methamphetamine overdoses, up however much percent in New Mexico. And I was like, what are these people talking about? I mean, I can say in 40 years of being on all different sides of this, I have performed medical intervention or been required to summon medical intervention for people for just about every other reason imaginable, but never for somebody that was using methamphetamines, right? Psychological intervention, yes, but never a medical, acute medical situation such as an overdose, like what we think of as overdose. And so the first thing I did was call one of our epidemiologists at the health department here and asked him to explain that to me. And we actually brought up the OMI data that report was based off of. And the first thing the thing that came up was that almost all of the individuals that were considered methamphetamine only deaths were mostly age 50 and older. And in the check boxes that OMI uses, there were some of the things that Dr. Coffin had mentioned, cardiac arrest, aneurysm, all these different things. And so the next thing I actually did was call Dr. Coffin. This was about a year and a half ago, maybe, just prior to, I remember what was happening, and it was just prior to COVID happening, and we had a big discussion about this, and it has since this and national conversations and things. I mean, people are throwing that word around a lot, and my point of view has always been what Dr. Coffin was sharing, which is that there's methamphetamine does have the potential to cause some damage to people who are like chronic or heavy users, and it can exploit other maybe genetic situations and things that people have. But calling people that are not, that it's not that it's impossible to overdose on amphetamine or methamphetamine, but you would have to consume a lot all at once, and that is just not how the majority of people use that particular substance, right? And particularly since what started happening in the mid 2000s into the present is selling methamphetamine in the form of what's known as ice, which is basically people take the finished product of methamphetamine and it gets dissolved in alcohol, and then the alcohol is evaporated and it reforms in these very, very hard chunks. And that makes it more convenient for smoking, right? And so really almost the majority of like use in the overall community has been people smoking this, and it's nearly impossible to smoke that much to where someone would experience an acute situation. And it's not that bad things aren't happening and that people are dying, but there's, I think that it requires some critical thought when looking at the situation. With regards to fentanyl, here in Rio Arriba County, we're one of the last places that it's actually shown up. We first identified it in any kind of consistent way in November of 2019. We started passing out the fentanyl test strips in right at when the pandemic started. We are not recommending that people use the fentanyl test strip technology on that. When the harm reduction community was caught off guard by fentanyl in the middle of the last decade, everyone was wondering what to do, and somebody figured out that the little strips, for those of you unfamiliar with it, that are meant for doing urine dips for UDAs, urine drug screen analysis, happen to also be able to check a substance for the presence of the drug or the metabolite, right? And that's one of the things, one of the nuances of fentanyl test strips versus, if you use a drug test that's meant for doing a urine dip for cocaine, for instance, it probably would not detect the presence of cocaine if you were testing a substance with it, right? It's checking for the metabolites of that drug being processed through the body. So that was like a miracle. There's something very simple that we could be providing, showing people how to use, and it's very effective for testing for the presence of fentanyl in opiates, heroin, and what we're seeing mostly now in our area is the counterfeit pills. They're very effective for that. I believe it was the Dope Project in San Francisco, where there was a lot of methamphetamine use at the time, was started reporting that all the methamphetamine that people that were using it was coming back was all positive for fentanyl. And it gave pause, and some folks looked into it, and it turns out that some of the chemical composition that is sometimes present or used in the manufacture of methamphetamine that was causing false positives using fentanyl test strip technology, right? And they developed a protocol that requires a great amount of dilution in order to get an accurate reading with that. All of that was also, there are drug checking projects across the country that are actually doing like spectroanalysis and things on substances, samples being provided by folks that are participating in programs such as ours. And there's a database out there, and you can go and look at all the different things that are being found. There's two in Massachusetts, and one in San Francisco, and one in Chicago, and one in Vancouver. You can go and you can look at the at what they're finding in these things. And so far, regardless of what you hear from law enforcement or on the news, there is no evidence that fentanyl is being introduced in any kind of coordinated way into methamphetamine, right? And I know there was that big report, the New York Times article a couple weeks ago, the CDC's, 2020 numbers, showing close to 90,000 drug overdose deaths in the United States during 2020. But then we had the head of NIDA on there talking about dealers putting fentanyl and methamphetamine to get them hooked. And, I really encourage critical thinking on those things. There is absolutely zero evidence from the street level through harm reduction programs that is actually occurring in any kind of intentional way. There are mistakes that happen. There was several people that overdosed at a party in Pennsylvania somewhere a year or two ago. They thought they were doing cocaine. They overdosed. It turns out that the person that brought the cocaine to the party grabbed the wrong bag when he came to the party, right? So there wasn't fentanyl in the cocaine. It was a mistake, right? And one of the simple ways to think about this is if cocaine or methamphetamine were being, if there was some kind of, that was actually happening in some kind of coordinated way, we would be having mass overdose events at bathrooms in clubs in big cities and at parties all over the country and in places where people are socially using these substances, and that is definitely not happening. So again, it's really important to put that in context. Now, I was just looking at drug checking stuff from Vancouver, British Columbia, yeah. And it's interesting that in mostly in pills that people are purchasing there, and they think that they're buying Xanax, for instance, methamphetamine is showing up as a substance in stuff that's being sold as other drugs, but not the other way around. So just put that in there. And I know I'm out of time, want to leave some time for questions, but during the past 40 years, there have been some changes in methamphetamine manufacturing that has led to a very different product from what you get, what used to be manufactured as methamphetamine. In 1988, the United Nations, whatever committee that meets every 2 years and figures out more prohibitionary stuff for the world, went after precursor chemicals and scheduled, among other things, the chemicals needed to manufacture methamphetamine from scratch. What that led to was by 1990, methamphetamine almost disappeared entirely. But then people started figuring out the do-it-yourself method. And according to the DEA's own data, in 1990, they only had methamphetamine lab seizures in 3 states. I think it was Texas, Arizona, and California. And by 1999, it was in 49 states, all except Rhode Island. And that was the spread of the do-it-yourself process, which begins not from doing what they call a racemic mixture, doing it from scratch, but starting with ephedrine or pseudoephedrine, right, which led to cold medicines being taken off the shelves and all the rest of that. When you manufacture methamphetamine starting from ephedrine or pseudoephedrine, you get a slightly different product as the end result of that. When you make it from scratch, like pharmaceutical amphetamine or methamphetamine, even disoxin, you end up with, there's 2 salts, right? There's amphetamine or methamphetamine salts. One of them is L-methamphetamine, which is a cardiovascular stimulant. and the other is D-methamphetamine, which is the central nervous system stimulant. When you start from ephedrine or pseudoephedrine and go for that, your end product is only the D-methamphetamine, which is the central nervous system stimulant. You know, the do-it-yourselfers are mostly out of business now in the United States, but the organizations that have been manufacturing methamphetamine in Mexico are using the second method. They're buying large quantities of pseudoephedrine from China and making these large quantities of that. So what people are doing nowadays is it's just the D-methamphetamine, and you'll hear law enforcement say that all the time, but pure D-methamphetamine, like it's a scary thing that would lead to overdoses. That's not really accurate, but what is happening is that people are, you're just getting the central nervous system stimulation, and it's not really something that's involving the rest of the body. And people get to a state where they overamp very, very quickly, right? And it begins to have diminishing effects or legs, as they say, right? Like the first time somebody does it, they might be up for a couple days, but very quickly, you know, there's nothing left, and it leads to that condition that people think of as overamping. And prior to fentanyl, methamphetamine users were coming to the program and saying, "Oh, they're putting heroin in the meth because I do it and I fall asleep," right? And now people are of the opinion that there's fentanyl in there because of the types of effects that it's having on people. So I know that's a lot of blah blah about the manufacture of methamphetamine, but the way that works on the body and stuff is, in my opinion, largely responsible for a lot of the types of effects and things that we're seeing. And when, you know, a lot of people think that you know, you can, if you go and buy Vicks, whatever, the cold medicine over the counter, it's got L-methamphetamine in it on the label, right? You know, it's not very much, but it's a cardiovascular you know, dilator. Some people think that is inconsequential to why people use amphetamines or methamphetamines. But if you look at Adderall, right, which is the most commonly used pharmaceutical amphetamine right now, it is 4 amphetamine salts, 2 D-amphetamine salts, and 2 L-amphetamine salts. And so it occurs to me that there must be a reason that a medication that is used to treat a psychiatric situation would involve both of those. There's a therapeutic reason why it's constructed that way. And I think that same reason probably has an impact in the types of side effects and the things that we're seeing amongst people that use methamphetamine these days. So.
Wow, thank you so much, Phil. That was so thought-provoking. I think this leads nicely into our question and answer discussion. So we'd like to now open our discussion up to the group. And if you would please either speak out a question or a comment or type it into the chat.
I think one of the things that really stood out to me that I didn't catch while Carla was showing the data from our study, again, you know, 30, 40 years ago, it was almost unheard of that folks who identify as Hispanic were at all involved in methamphetamine use, up until even through the middle of the last wave of that in the mid-2000s. It was almost entirely considered a white person's drug. And in the 20 or so years that I've been working up in this part of the state, in northern rural New Mexico, this community was nearly 100% immune from methamphetamine. There's been heroin here for a really, really, really long time, but but methamphetamine use in this community is relatively recent. And when it started showing up about 3 or so years ago amongst the folks that use our harm reduction services, being reported to us as a factor in overdoses that people were responding to with naloxone, right? They were saying, oh, yeah, we'll say, do you know what was the person doing? And they're like, they were doing that damn speed, right? So, you know, that's something that we've seen creep in and become, and then just kind of explode now that we've had fentanyl in the community.
I think that's exactly why we wrote this grant together, isn't it?
Yes.
You told me that.
Thanks, Phil. Phil Coffin, and thanks, Carla, and thanks, Phil Feudy. Phil, what do you think your clients, how do you think your clients would view medication for methamphetamine dependence?
You know, I think my guess is that there's probably, you know, there's some openness to that, but it's also sort of my feeling at this point that the majority of the individuals that we work with are also don't consider methamphetamine a primary factor in their lives. They're, you know, they consider themselves that they use heroin or they use pills or they use these other things, and the methamphetamine is just kind of slid in there into the mix. So I haven't really talked to anybody at all that has expressed any concern in their methamphetamine use or interest in somehow eliminating that from their lives. So
I think that's really interesting because so many people who use it describe it as a very functional drug. And yet we see, as you know, Phil Coffin presented, a lot of negative health outcomes. So I'm not sure what kind of steps need to be. I mean, definitely, you know, when HIV was really associated, you know, that spurred a lot of interest in medication, but how do we keep that going in the app? You know, how do we, I'm not sure what next ways forward are. I'd love to hear from Phil and Carla too about that, or anyone else in this amazing group of people that it's joined.
I mean, I guess I will just kind of reiterate some of the qualitative data that are coming from our study, and then Phil Coffin can step in with the medicine. But I think you're right that people are talking about their methamphetamine use as functional. And when they're talking about what they want from a therapeutic, they want that same function. And so I know, is it just a safer stimulant we're looking for? Or, and then I will just add on to that I was really struck by Philip Coffin's talking about, and we've heard the FDA talk about this too, in terms of defining meaningful treatment trial outcomes for patients, that, you know, maybe abstinence is not where it's at here, and it's just reducing the overall load on the system. So I don't know what our options are, but I'm happy to ask the people what a meaningful outcome would be for them.
Yeah, our criteria for, I mean, obviously I'm doing a lot of treatment studies, so I'm seeing a lot of people who want to reduce or stop methamphetamine use. I also, as an HIV provider, I see, you know, my patients who come in who use methamphetamine, not all of them, some of them enjoy using it and have no interest in stopping, but I'd say at least half of them really want to stop. and are unable to, or really want to cut back substantially and are unable to. So there's definitely a lot of interest out there in getting a handle on one's methamphetamine use. I mean, honestly, most drugs that people use, if they could keep using them but do it in a controlled fashion, that's the goal outcome for most people with the substance use disorder. And when you can achieve it, that's a win-win. I wish we had a quantitative assay for methamphetamine use. That would be the breakthrough that would totally change the game for pharmacotherapy development. And
Larry, sorry, go ahead.
The closest I've found was this thing that John Mendelsohn came up with, where basically you administer radio-labeled methamphetamine to somebody, you watch its metabolism, you keep them inpatient, and you collect their pee, and then over time you can develop an individualized way to assess methamphetamine exposure in an individual person. So there's no way. First off, I don't think that would actually work, even if you could, run each potential study participant through an inpatient protocol to develop their individual data. Then they'd leave, and you wouldn't know when they were exposed to methamphetamine, to the time, and et cetera. It's not non-viable. But I wish we had the tools that alcohol research has.
That's really interesting. Larry, you see a totally different patient population, pregnant women. What do your clients want? What do your patients want, I should say?
I think most of them actually do want to at least get off of meth during the pregnancy. They don't want to be at risk for issues coming up with their baby. Some of them want to breastfeed. So I think that, there's a desire for that. On the other hand, a lot of people are coming to see us not because they're like ready to treat their addiction, but simply because they're pregnant, and everybody around them, whatever family friends, are like, you need to do something now. So it's kind of a mixed. It's sort of mixed there.
I'd love to hear from anyone else who is seeing patients or clients with using methamphetamine.
Or a question I have that maybe Philip knows more on. I know that there has been some work done, some clinical trials done in using existing amphetamines in an effort to come up with this. I know Alex Wodak did something like that down in Australia, and there's been some work in Canada and a few other places with that, but I hear about it and then never hear about it again. And I'm just curious if there's any information about that.
So the studies on amphetamine type stimulants are mixed. Methylphenidate has probably maybe the best data. It's confusing whether or not, I'd say overall the studies probably suggest it's better for somebody that, you get a little better efficacy out of it if it's somebody who has, a real ADD type syndrome as well. It's used for sure off-label mostly by psychiatrists. The barriers to it are you're prescribing a controlled substance. So technically, it probably falls under the same rules that make methadone only prescribable from an OTP. So you might arguably be in some federal violation by doing it. I'm not sure. From the 1920s Supreme Court decisions that addiction is not a disease, so you can't use controlled substances to treat it. It's a tricky domain, and it also, stimulants, in contrast to opioids, stimulants have cardiovascular harms, and you can take opioids your whole life and suffer constipation and reduced libido, but no reduction in your longevity. you can't do the same with stimulants. And especially as somebody's aging and blood pressure tends to go up, so you have hypertension and cardiac disease rising, stimulants become potentially a real harm for somebody, even controlled stimulants, especially if it's just cumulative exposure and not like the binge exposure that is associated with negative outcomes. So those are the concerns. I think it's a valuable tool in the toolbox, but it's only one tool, and it has those potential hiccups.
In the interest of time, I just want to thank our presenters once again, Dr. Philip Coffin, Dr. Carla Wagner, and Phil Feudy. Thank you to everyone who has joined us today.